Hi friends, today I will talk about nocturnal dip in the blood pressure. First is the disclaimer. The normal physiological fall in systolic and diastolic blood pressure is about 10 to 20% during the sleep as compared to the daytime blood pressure. And this is known as normal or nocturnal dipping, and the subjects are known as dippers, or we can say normal dippers. The different abnormal BP dipping patterns during the sleep in the night are when the decrease in the blood pressure is more than 20%. This subset of the individual are called extreme dippers. If the decrease is less than 10%, they are called non-dippers. If BP during the sleep increases instead of its normal physiological fall, the individuals are reverse dippers or the risers. The hypertensive patients who do not show phenomenon of nocturnal dipping may have been associated with development of target organ damage such as left ventricular hypertrophy, microalbuminuria, and occurrence of cerebrovascular and cardiovascular events. The clinical correlation of the nocturnal dip in blood pressure is the non-dippers are patients with reverse dippers or nocturnal hypertension. It has been seen that several studies show that less fall in nocturnal blood pressure in relation to daytime blood pressure or night day BP ratio was associated with increased poor prognosis irrespective of the 24-hour blood pressure level. Less fall in nocturnal BP non-dippers or high nocturnal BP is a risk factor for cardiovascular diseases as well as marker of pre-existing or concurrent disease that can cause nocturnal hypertension. Non-dippers and reverse dippers are risers. They are associated with increased risk of death, myocardial infarction, and stroke, and both these patterns may also cause nocturnal hypertension. The various factors and associated conditions responsible for nocturnal hypertension or the non-dipping patterns of the nighttime blood pressure are the possible mechanism are volume overload, which is seen in heart failure, chronic kidney disease, high salt intake, salt sensitivity, autonomic dysfunction seen in diabetes mellitus, orthostatic hypotension, renal or cardiac transplantation, poor quality of sleep seen in obstructive sleep apnea, sleep deprivation, insomnia, restless leg syndrome, narcolepsy, nocturia, neurophysiological disorders like depression, anxiety, stroke, cognitive dysfunctions, hypertension, lifestyle related factors like obesity, metabolic syndrome, smoking, alcohol, stress, shift work, increased nighttime activity, and reduced daytime physical activity. Miscellaneous factors are Asian population, aging, low socioeconomic state, and environmental factors. Many studies have shown that cardiac hypertrophy, silent cerebral infarction, microalbuminuria was more common in non-dippers than the dippers. The patient with nocturnal dipping resistant hypertension had twofold higher risk of cardiovascular morbidity and mortality than those of dippers. The reverse dipping consistently showed poorest outcome among different types of dipping. The subjects with reverse dipping had the highest incidence of stroke. The incidence of hemorrhagic stroke was higher in reverse dipping group as compared to the other dipping groups. The patients who had reverse dipping were older, male, and lean. Extreme dippers have higher prevalence of silent cerebral infarction, deep white matter lesions, and silent myocardial ischemia during the sleep than the dippers. This is the pathophysiology, circadian rhythm, autonomic nervous system, water and sodium, water retention, sodium and water retention. They play important role in the non-dipping. So the circadian rhythm, autonomic nervous system, water and sodium regulation, they play important role in the pathophysiology of the nocturnal dipping. As we know that normally at night time the blood pressure normally drops at the night by 10 to 20%. This is the normal dipping pattern. It is because of decreased heart rate, which is because of decreased cardiac output. The stroke volume and the systemic vascular resistance, they usually remain stable or slightly increased at night. So lower cardiac output because of decreased heart rate leads to lower blood pressure. The non-dipping or the nocturnal hypertension is seen in small seen is it is seen when there is small drop in cardiac output due to less reduction in heart rate or increased stroke volume during the sleep, increased systemic vascular resistance, overactive sympathetic nervous system, and poor overactive sympathetic nervous system. They contribute to the non-dipping or the nocturnal hypertension. The poor melatonin secretion, like as we know that melatonin helps to dilate the blood vessels at night. When its levels are low, there is less vasodilatation, and it leads to higher nighttime blood pressure. The circadian clock and BP regulation is maintained by the central clock in the brain, that is the suprachiasmatic nucleus, which controls the rhythm of many body functions, including the blood pressure. It communicates with the autonomic nervous system, endocrine glands like pineal gland for melatonin production, and peripheral clocks in the heart, kidney vessels. They also contribute to this rhythm. So, in the pathophysiology of the nocturnal dipping, the sleep plays important role. In the non-REM sleep, parasympathetic system is dominant, so the BP drops. In REM sleep, sympathetic activity rises, blood pressure may increase, so poor sleep or sleep interruption during the night may lead to more REM sleep pattern, and it leads to less BP dipping. The sleep disorders and the non-dipping is seen in obstructive sleep apnea. Obstructive sleep apnea causes repeated drop in oxygen and activates the sympathetic nervous system. It is strongly linked to non-dipping or even rising of the nighttime blood pressure. CPAP therapy helps in some patients but may not fully restore the dipping. The salt water in the volume overload states seen in chronic kidney disease or heart failure also contribute to the non-dipping pattern of the hypertension. The autonomic dysfunction in special conditions like Parkinson disease, multiple systemic atrophy, spinal cord injury can blunt the normal autonomic control, and this can cause non-dipping or even rising blood pressure at night. The supine hypertension, that is the blood pressure, increased blood pressure when lying down, may occur due to pulling and the shifting of the blood. So the normal dipping, that is nighttime normal dipping, is because of decreased heart rate, stable systemic vascular resistance, high melatonin level, good sleep, and the normal circadian rhythm. When the circadian rhythm is disturbed, it leads to non-dipping or the nocturnal hypertension, and in these patients the heart rate doesn't fall, cardiac output remains high, the systemic vascular resistance increases due to sympathetic activity. Such patients have low melatonin level, such patients have poor sleep, obstructive sleep apnea, and they have repeated sleep arousal during the night time. Role of gut microbiota and its metabolites in blood pressure dipping pattern. It is little understood. The dysbiosis means an imbalance in the gut microbiota caused by various internals, diseases, and external factors like diet or antibiotics. The gut bacteria, they play an important role in diabetes, obesity, inflammatory bowel disease, liver disease, chronic kidney disease, and hypertension. In experimental models like dal salt sensitive rats, certain bacteria like Sutrella have been linked to the nocturnal blood pressure dipping pattern. However, more human studies are needed to confirm this link between the gut bacteria and the daily BP patterns. The gut metabolites, that is postbiotics and BP regulation. The gut bacteria produce metabolites known as postbiotics, including short chain fatty acids, acetates, propionates, butyrates. These short chain fatty acids are now recognized to influence the BP regulation. Recent studies have found that non-dipper patients whose blood pressure does not fall at night have higher level of these short chain fatty acids in their stool as compared to the dippers. This was constant in both men and women, and this suggests that the gut microbiota and its byproducts may play a key role in maintaining the normal circadian BP rhythms. The therapeutic implications of nocturnal BP dipping are only a few studies have shown that restoring the abnormal blood pressure during the dipping pattern and normalizing the nocturnal BP may be beneficial. However, it is not very clear that doing so will improve the prognosis. The HOPE study showed that the bedtime administration of ramipril reduces the nocturnal blood pressure as compared to the morning administration. But Hermida et al. In the follow-up study analyzed that the changes in the ambulatory blood pressure monitoring, which revealed that 5 mm mercury reduction in nocturnal systolic blood pressure was associated with 17% reduction in the cardiovascular events. Though these are of no Though there are no global scientific guidelines for the treatment of non-dipping or the nocturnal hypertension, it appears logical to treat the pathophysiology of or the underlying altered diurnal BP variation, including the nocturnal hypertension. The salt restriction as circulating volume overload may contribute to the nocturnal hypertension as well as non-dipping pattern, the salt restriction and thiazide diuretics, including the natriuresis, not only restores the abnormal nocturnal blood pressure variation but also the nocturnal hypertension. Modification of autonomic dysfunction. There is only one positive study in favor of using alpha blocker, that is doxazocin, at night time for reducing the nighttime blood pressure. Renal denervation also significantly reduces the nocturnal blood pressure. Lifestyle modification like reducing the weight, activity, increase activity or supportive measures to improve the quantity and the quality of the sleep and proper management of psychiatric and neurological diseases are also associated are necessary to deal with the nighttime blood pressure. Asking patient to avoid alcohol and smoking totally helps in restoration of nocturnal hypertension. In normotensive cohort study, the obstructive sleep apnea severity was associated with higher nocturnal blood pressure, which improved following the CPAP therapy. It was found that intermittent hypoxia was most important factor in mutual association of nocturnal blood pressure and obstructive sleep apnea. The chronotherapy, it is a scheduled administration of pharmacological agents with respect to individual circadian rhythm that may enhance the efficacy of the pharmacological agents. Administration of at least one antihypertensive drug at bedtime has been reported to be more effective than morning dose. It restores the circadian variability in blood pressure and reduces the nocturnal blood pressure and also the cardiovascular events with total mortality. Use of chromotherapy with angiotensin receptor blockers, Ramipril, and calcium channel blockers had shown beneficial effects in reducing the prevalence of non-dippers and improving the nocturnal blood pressure fall more significantly. However, recent global hypertension guidelines do not recommend any nighttime blood pressure medication to reduce the nocturnal blood pressure. The circadian rhythm disturbances. The disturbances of circadian clock is associated with abnormal behavior patterns such as short sleep duration, shift work, hectic lifestyle, and sleep apnea. Hence, these changes in such daily routines are a fundamental component in avoiding the disturbance of the circadian clock. Melatonin or its receptor agonist supplementation. A decreased nocturnal surge in melatonin excretion from the pineal gland, which activates the suprachiasmatic nucleus, has been reported in non-dippers. So, the melatonin or its receptor agonists have been found to lower the nocturnal blood pressure in hypertensive patients. However, the mechanism by which melatonin acts as to the target the circadian BP regulation is not clear. In conclusion, nocturnal dipping of the systolic and diastolic blood pressure during sleep recorded by ambulatory blood pressure monitoring is a normal physiological phenomena. Non-dippers, that is less than 10% of the fall in blood pressure at night time and a nocturnal hypertension, are strong predictors of cardiovascular events and the target organ damage. Non-dipping pattern is also associated with many lifestyle factors like alcohol consumption, smoking, grease, salt intake, stress and night shift working. Reverse dipping pattern showed poorest outcome and highest incidence of hemorrhagic stroke, while the extreme dipper patterns was found to have silent cerebral infarct and silent myocardial infarction. Hence, it is important to deal with these patterns while treating the hypertension, especially the masked hypertension, white coat hypertension, and resistant hypertension. Only few studies are available that favor the treatment of non-dipping blood pressure, that is removing the behavioral factor as mentioned above, and nocturnal hypertension. As such, there are no scientific guidelines worldwide. Hence, further prospective studies are needed to explore these dipping patterns. These are the reference from which I have taken this article. Observation, reason, human understanding, courage, all these make a good physician. It was said by Martin H. Fisher. With this, I conclude my today's topic. Thank you. Keep learning.